of angiotensin, which is converted to angiotensin 2, and then you have consequently a release of aldosterone. So angiotensin 2 helps to cause vasoconstriction of your blood vessels, and again, that helps to increase your total peripheral resistance. Whereas aldosterone helps with sodium and water retention. So you're retaining more water, which helps increase your blood volume, which again helps increase the venous return to your heart. Okay, so that's all working towards increasing your cardiac output. But there's a problem with that happening, and that's where this diagram sort of comes in. So I know it looks complicated, but it's actually pretty straightforward. So it's pretty much what we discussed right now. So, you know, we have reduced cardiac output. You have your sympathetic nervous system activation as well as renin release, okay? And renin, your activation of your RAS also happens by the juxtaglomerular cells sensing that decreased renal perfusion. So either way, angiotensin 2 as well as sympathetic nervous system activation helps to cause vasoconstriction, and that again is working towards increasing your filling pressure. And at the same time, aldosterone helps to cause increased sodium and water retention. Okay? Now what's happening though is that all this increased blood volume that's coming back to your heart means that you have a lot more blood to pump out. And because you already have a ventricle that's not functioning properly, it puts this extra pressure and this extra load on your ventricle to try and contract. So now the ventricle has to try and contract even more forcefully to push out all that blood. So you kind of have this vicious cycle where it starts to cause cardiac remodeling. Okay, and that goes back there. So in response to more blood and more pressure coming back to your heart, the heart starts to change the way it's shaped. It gets thicker, so you have hypertrophy. You start to get a bit of ischemia because it's not working optimally. So you get all these changes, and that's why you kind of have this vicious cycle. So even though your body kind of responds to increase that cardiac output, you will never actually reach sort of that optimal cardiac output, and that's when you get chronic heart failure. Okay, so so this pretty much is explaining the renin-angiotensin part of it. So here you have your decreased cardiac output. You've got your sympathetic nervous activation as well as your renin-angiotensin activation. So all that pretty much comes up to is you have more vasoconstriction as well as more water retention. So that extra blood volume causes an increased preload, okay? So that's the blood coming into your ventricles. And the vasoconstriction, which is causing an increased blood pressure, causes an increased afterload. The afterload is the pressure that the heart has to, compensate for to contract. Okay, so the increase in both the preload and afterload means that your heart has to work even harder to pump out the same volume of blood. And that is what causes your cardiac remodeling. So you have damage to your myocytes, you have hypertrophy, all those kind of things, and that is what comes back and leads to more heart failure, so chronic heart failure. And that is pretty much just sort of explaining how it works. So you have more blood kind of coming into your ventricles, your heart muscles stretch out, and just remember, it's like all that physics stuff. I think it's like Laplace's law or something, where you have to kind of contract more forcefully. So that's pretty much what's being shown over here. So does anybody have like major concerns about that question? Like, I reckon if you probably did this, you're in pretty good shape. It's not that complicated. You start with sort of the basics, and then you kind of add all the extra arrows. All right, so the second question was to do with treatments. So this is just pretty much what's recommended. There's like heaps of different combination of drugs that are used for heart failure, and it depends on what other things are going on. Does the person also have, coronary heart disease? Do they have hypertension? All these other things. But pretty much in terms of first-line drugs, you have like a couple of big classes. So you have your diuretics and you have ACE inhibitors. Okay, so I've kind of looped. I've kind of like put diuretics together. So, but under that you have like a subclass of loop diuretics, which is your furosemide, and that pretty much works to increase your urine outflow. So, you know, because we have, like, we were talking about this water and sodium retention causing an increased blood volume, which is sort of affecting your ventricles because they can't cope with it. So furosemide works towards that to kind of reduce that increased volume of blood. So you have more urine outflow, and that's because of inhibition of that co-transporter. So decreased blood volume, decreased blood pressure, decreased load on the heart. Then you have your potassium-sparing diuretics, and that is spironolactone. And that, again, prevents potassium secretion. I think that's more to do with contractility. I'm not exactly sure. That was supposed to be like a completed statement there, but I'll find it out, put it up. Okay, and then your ACE inhibitors. So they pretty much prevent the conversion of Ang1 to Ang2. So if you don't have Ang2, you don't have vasoconstriction, and you also don't have production of aldosterone. So no water and sodium retention. So again, that's working towards reducing the preload and afterload of the heart. So yeah, decreased afterload because you have decreased constriction because of lack of Ang2, and decreased preload because of decreased fluid retention because of aldosterone. Okay. Oh, and that's just sort of talking about a different combination of drugs. So ACE inhibitors are contraindicated. So if they have like hypotension, or if they have hyperkalemia, or acute renal failure, etc., then you would use a beta blocker instead. Okay. So second-line drugs, so that's your beta blockers. So they pretty much decrease heart rate and decrease contractility. So metoprolol is specifically a beta-1 selective drug, okay? But you know, you guys remember there's like non-selective and all those, so you know, there's different options there. So it works in two ways. So it decreases heart rate and contractility through, like, you know, decreasing the sympathetic nervous stimulation, but it also decreases renin release. So you have less activation of your renin-angiotensin system. And then vasodilators, so this is the most common combination of vasodilators used together, but then there's other options as well. So pretty much it's a nitrate and hydralazine. So the nitrates are mainly venodilators. So when you dilate your veins, you're going to cause a decreased preload. Whereas hydralazine mainly dilates your arteries, so that will cause an decreased afterload. So if you have larger arteries, you have less pressure in them, so less pressure to overcome to contract the heart. So you have a decreased afterload. And then third-line drugs. So these aren't as important, but they may be used in some circumstances when there are like contraindications. So cardiac glycosides, specifically digoxin. So it inhibits your sodium-potassium pump, and that's by, like, I think, inhibiting cyclic AMP and all that stuff. You don't need to know like all the details about all that, but pretty much because of that, you're going to have a buildup of intracellular sodium, and you're going to have less efflux of calcium. So you're going to have more calcium inside your cells. If you have more calcium inside your cells, you're going to have more contractility of the heart, and that helps to increase your cardiac output. Phosphodiesterase inhibitors, I mean, I probably wouldn't even mention that as, you know, your first choice at all, but it is, like, it does sort of come under, like, third-line drugs, which is why it's there, but pretty much it inhibits the degradation of cyclic AMP. Again, the same thing. You have more calcium inside your cells, increased contractility. It also causes a bit of arterial dilation, but that's all a matter of the concentration at which the drug is given. And that helps to decrease afterload. Now, we've talked about like pharmacotherapy, but just remember all of the drug options have to be done with lifestyle modification, okay? So your non-pharmacotherapy is lifestyle changes. So you want to be on a fluid and sodium restricted diet. You want to, you know, have some sort of like exercise therapy, quit smoking, reduce alcohol, like all your cardiovascular, you know, risk factors that you talk about, aim to lower those. All right, then the third part is the chest x-ray. So I apologize that there isn't actually a chest x-ray, only because it's really hard to kind of find one that shows all of it. And to be honest, I'm not that great at reading chest x-rays, so I don't even know what to point at. But this is pretty much the main things that are kind of diagnostic for left ventricular failure on the chest X-ray. So if you remember the mnemonic A, B, C, D, E. So A is alveolar edema. So that's like that bat-wing appearance that you get, sort of up here. B is interstitial edema, but that's referring to the curly B lines. Yeah. Cardiomegaly is just an enlarged heart. So for cardiomegaly, it needs to be, I think it needs to occupy more than 50% of the chest X-ray. Dilated prominent upper lobe vessels, that's up here, and pleural effusion that you would see at the corners. So, I mean, if you guys want to look up an actual chest X-ray, I'm sure you can just go Google it. Sorry?
Can you go virtual slides?
Yeah, I think there is one on virtual slides. Yeah. This is just sort of to kind of give you dot points of what are the things you should be looking out for, because it's also something that could be asked in your OSCE component, you know, as a question at the end. They might say, you know, what would you look out for on a chest X-ray? And these are some of the things that you could mention. And lastly, the Framingham criteria for congestive cardiac failure. So for it to be diagnostic, you need to have the presence of 2 from the major criteria, or 1 from the major and 2 from the minor together, okay? So these are some of the signs and symptoms that we include in the major criteria for the Framingham criteria. So PND, crepitations, the S3 sound, cardiomegaly. So like I mentioned, you know, it has to be more than 50% of the cardiothoracic ratio on the chest X-ray. Increased central venous pressure, neck vein distensions. These are things you'd observe on examination. Acute pulmonary edema, hepatojugular reflux, and weight loss of more than 4.5 kilos in about 5 days after treatment. Okay, so that is part of the major criteria. The minor criteria includes, again, things that you would notice from your history and exam. So bilateral ankle edema, dyspnea on normal exertion, tachycardia, so more than 120, a decrease in vitral capacity by about 1/3 from the maximum that was reported, hepatomegaly, pleural effusion, nocturnal cough. So, yeah, that was, does anybody have any major concerns about any of those questions? Any questions? So I don't remember who asked me, but in terms of that MCQ, so it's not that ACE inhibitors are contraindicated. It's more that with coronary heart disease, where you have narrow blood vessels, you want to use drugs that are going to help dilate those vessels the most. So that's why we use beta blockers and dihydropyridine, because dihydropyridine has like a dilating effect on your vessels. I think like when those drugs are contraindicated, you can use an ACE inhibitor or another form of calcium channel blocker, but this is like the first line use of drugs. So it's about trying to find the best combination. If you guys go back and look at the slides from that lecture, it kind of, I think, explains it more, and I think it's one of the last slides, so it does go over details of antihypertensive, consider that. If you guys have any questions, I mean, you can